I'm too short, I have to move this down. Well, thank you for inviting me here today. And I'm here really to talk about some of the impacts of the investments that we make in early and later childhood on HIV risk behaviour and other issues in adolescence. And I'd like to acknowledge my co-author, Professor Lorraine Scher. Many of these ideas came about around her kitchen table, eating bagels and drinking tea. But this research is really a set of findings that have come about through a set of discussions with policymakers and programmers. And over the past year, with UNICEF, with UNDP, with colleagues at the World Bank, and with PEPFAR, we've been essentially doing something like a sort of social protection and cash transfers world tour, a slightly lower grade world tour. But going around and speaking to policymakers in sub-Saharan Africa about the evidence for social protection and what their needs are in terms of research and knowledge. And I don't know if it's good or bad, you can tell me, but this is certainly research shaped by the demands of policy. Well, this study was never meant to be a study of social protection or cash transfers, and I was never meant to be studying that. This started off as a longitudinal study of the impacts of family HIV/AIDS on children. And essentially what we did was, in South Africa, we selected 3 provinces. They weren't randomly selected. Government had a bit of a say in which provinces we chose. But within those provinces, we randomly selected 1 rural and 1 urban area, big health districts. And within those health districts, we randomly selected census enumeration areas in the urban areas and tribal authority areas in the rural areas. And then within each of those areas, we interviewed every single household with a child aged between 10 and 17. That gave us an initial sample of 6,000. We then ran out of money in 1 province, but in the other 2 provinces, we went on and did a longitudinal study with a 97% follow-up rate. That means we think we can be quite robust in saying that we've got a good number of the kids followed up. We've got a very good follow-up rate, so we shouldn't have too much attrition bias. And also that we've got something that we hope is at least representative of these very poor areas. I'm happy to answer any other questions about methods that you've got later. But when we were halfway through this study, Rachel Yates at UNICEF cornered me in a corner in Addis. And she said, can you just please look at whether cash transfers are making any difference in HIV risk behaviour? They were desperate to know, and they didn't have any evidence. Well, it took about 8 months for us to work out how to do this. And eventually we used propensity score matching, which is a kind of way of simulating a randomized control trial. What you do is you match participants on every other kind of characteristic. We matched on about 300 characteristics. And then you chuck out a whole load that don't match with anyone. And then you look and see whether getting the intervention, which in this case was the child support grant, a small amount of money that the South African government delivers to about 60% of the children in South Africa, and see whether that made a difference on sexual risk. Well, the news was mixed, but it was very promising. We found that for girls receiving a child cash transfer in their family had a 50% odds reduction in transactional sex, that's sex in exchange for money or food or school fees, and they had a 70% odds reduction in the risk of age-disparate sex, and that's sex with a partner more than 5 years older than you. These are 2 massive risks for HIV infection for girls in sub-Saharan Africa. But what's also interesting is what it didn't do. It didn't work at all for boys in terms of HIV risk, and it didn't work on some other sexual risk factors. It didn't change multiple partners, it didn't change unprotected sex, it didn't change sex when you're getting drunk or taking drugs. What it seemed to be doing was not changing the kind of stupid stuff teenagers do, but it was allowing teenage girls to make the decisions about who they wanted to have sex with. They weren't needing to have what we call in sub-Saharan Africa a sugar daddy to pay their school fees. Instead, they were able to choose to have sex, even slightly risky sex, with younger boys who were much lower HIV risk for them. But this is all very well, said David Wilson at the World Bank when I spoke about this a few months ago in Cape Town. But it's not doing enough. And what he was thinking was that we should be introducing conditionality. But we also took a step back and said, okay, if cash isn't enough, do we need to be adding something to cash to make it work better? Well, what we ended up finding was the most effective addition to cash was care. And in this case, cash we expanded to include free school feeding, free schools, and food gardens. And care was positive parenting, visiting, home-based visiting, school counselling, and teacher support. And what we found, and we looked at a whole range of HIV risk factors. We looked at all the ones that we'd looked at before. And we found quite different results for boys and girls. For girls, cash alone does reduce your incidence of HIV risk behaviour. But cash plus care has an additional benefit. For boys, to our surprise, cash alone did nothing, just as it did in the previous study. But cash plus care resulted in a 50% odds reduction in HIV risk behaviour incidence. It seems to be that even though the boys in our sample looked like they were kind of cool teenagers, they really needed that psychosocial support combined with the basic income in order to reduce their HIV risk. Well, we presented this in Geneva and presented it in Johannesburg, in Nairobi, and around sub-Saharan Africa. And one of the things that policymakers kept saying to me was, how is this working? You know, for them it was a black box. We were telling them, put cash transfers in and get HIV risk reduction out. And so we sat and tried to really work out what are the mechanisms by which these interventions might be making an effect. And what we found, and this took us months and months because we kept trying things and it wasn't making sense, what we found is a very clear set of interrupted structural risk. And this is a very simplified model. On the left, we have structural deprivation. Now, within that is living in an AIDS-affected family, living in an informal settlement, living in areas of high community violence, and living in contexts of extreme hunger. What happens is those go through a set of mediators of increased psychosocial risk. So increased abuse, increased school dropout, increased psychosocial problems and delinquency. And through that leads to HIV risk behaviour. Now, cash and care do interesting things. If you look at the black lines, you can see that they directly reduce the psychosocial risk and the HIV risk behaviour. But if you look at the red lines, you can see that they have what we call a moderative or interactive effect. It means that they work better for the most structurally deprived, and they work better for those with the most psychosocial problems. So in a sense, we're seeing partly what someone spoke about this morning is reducing the inequalities that these children are starting off with. The last thing, and this is work that we're really still going, and we did the last analyses for these on the plane here from Dubai to Delhi. But one of the things that has come up repeatedly from UNDP and from other colleagues is the need to understand cash and care within the context of the wider world. Coming from the HIV world, we think HIV is the sole thing we should be looking at. But as the new Sustainable Development Goals come, and especially from governments' points of view, they don't want interventions that just have one hit. They need interventions that are going to have multiple hits across multiple domains of a child's life. And we see that for girls, we get reductions in things like pregnancy has a 50% odds reduction for cash alone and a 70% odds reduction for cash and care. But we're also seeing impacts on school dropout. For boys, we see less impacts on sexual risk, but impacts on both school dropout. We see a 90% odds reduction with cash and care for school dropout, and also on criminal behaviour. That wasn't just delinquency, that was actually criminal acts in adolescence. So how do we think about this in terms of investment in early and later childhood? And this is something I'm still really struggling with. We know, and there's good evidence, that the earlier you put in these interventions, the more impact they have. We've seen that not only in the great research that's been done on things like parenting programs and cash transfer in Latin America, but also in studies done in South Africa, where the earlier the child support grant is received, the more HIV risk reduction we see. But we also know that the risk is going up as these children are getting older. And we're also seeing that unless these interventions are sustained, they don't work. When we look at our analyses, time one, cash transfers and care, does not predict time two outcomes unless the cash and care is sustained across the period. So I think it's a really big question for us. So what do we know? We know from this that cash plus care can reduce HIV risk and mitigate structural risk. We can also see a range of benefits across different domains. We can see that they need to be sustained in order to work. And I think what's really encouraging about this is not a randomized control trial. It's not that level of quality of evidence. What it is something that shows us that what's really happening, government, cash transfers, NGO programs, family support, with all the mess of the real world of sub-Saharan Africa, is really working. Thank you.